you up.
Thanks. Thanks for putting in the new ones.
It's okay.
It'll actually go faster this way.
Okay. That's
one.
That's the pointer.
All right. So, and that progresses. Cool.
Usually. Okay, we're going to the next section where I'd like to introduce my colleague and friend, Dr. Alex Vasquez. Alex is a repository of an enormous amount of information and data. He holds 3 individual doctorate degrees in different disciplines. And I know I kind of get through a lot of material every day, but if we get stuck in one of those back and forth emails, he kills me by about 4 o'clock in the afternoon. So we did a lot of information exchange, and Alex also writes a lot of material. He'll probably be too shy to point it out too much. But he's written a number of books, and I certainly recommend that if you want to try and consolidate a lot of the information you've had today and add to it, that you can buy his books from Amazon. And they're definitely a worthwhile investment for your future going forward. So, I'd like to put your hands together and welcome Dr. Vasquez.
All right. I think the mic's on. I think we're good to go. So, thanks for the introduction, Mike. And indeed, I've updated the slides just a little bit from this morning. I made a new video last week, for example, and I included some of that information here. The video is available online for free. I'll show you how to get that if you want to take a look at it. But something that's important for me, and I think for Mike as well, is to put things in context. So for that matter, for that reason, I've added those slides that I just mentioned. And the purpose is to show you things that we haven't shown in these presentations before, such as the interconnection between microbes and mitochondria, and as Mike mentioned earlier, mTOR. I think mTOR is very important. The video that I just posted yesterday is on mTOR. I'll show you an excerpt from that. So, slight modification to this introductory slide. What I'm going to start with is, of course, some introduction perspectives and a few updates that I just mentioned. It's going to be what I would call quasi-linear, in contrast to the rest of the presentation, which will be very linear. Part 2 is just going to be cases, and we'll just go through cases, and I'll show you how I worked up patients and some of the ones that I treated. But if you want the video that I just mentioned, it's online for free at vimeo.com/Dr. Vasquez, and you'll see this information again, so it's not your only chance to get it, but I'm just trying to make this information available to you because I am updating this information exactly right now. So as many of you may know, for example, I published a lot of work on dysbiosis in 04, 05, 06, and a lot of that information kind of stayed stable because it was, I thought, pretty good. But I am updating that information right now very assertively, like on a daily basis, basically. So things are changing in my own delivery of this information right now, which is why I'm trying to provide you the access to the updates. So I, as many of you know, have done some consulting work for Biotics Research Corporation. And here's an example of how things have changed, at least in my own appreciation. So I actually created this diagram about 10 years ago. And at that time, I thought, well, it's a reasonable understanding of what we know now about dysbiosis. It's in my rheumatology books, for example. But I just want to show you the update. So again, this was the previous version. And what I've tried to do in the conversation about dysbiosis was maybe we could say try to disprove the disprovers. Because if we just say dysbiosis or if we just say microbiome, in my opinion anyway, without having a molecular understanding of what exactly is happening, then it just remains this vague concept that I would feel more comfortable with if I had and if we all had a better mechanistic understanding. So for example, perfect example is every day we're seeing articles published on the microbiome in the brain. In fact, a new article was just published on Medscape this morning. So we're seeing microbiome and brain, but I'm not seeing any of those articles actually detail the mechanisms. And so one of the things I've done in kind of revamping this work is get into more detail. So I considered this somewhat detailed, especially for the era 10 years ago, but now things have changed, and I think not only is my work more colorful now, but it's also, of course, more detailed. And we have new mechanisms here, and I'll touch on those. So this presentation, as Mike mentioned in one of his first presentations this morning, we've kind of pretty much got it down to the minute. So I can't spend a lot of time going on updates when I've got to get through the cases, but I do want to point out a few things that have changed. And Mike, as he already mentioned, we've talked about this by email quite a bit. So what we appreciate now that we didn't appreciate, for example, 9 or 10 years ago, is that microbes do affect mitochondrial function, as you can see here, mostly creating this situation that we call mitochondrial hyperpolarization, which ultimately changes the way the immune system works to make it predisposed towards inflammation and autoimmunity. So, you know, even 2 years ago, for example, I remember lecturing on microbes and mitochondria, and all we could say at that point was mitochondria seem to sense microbial presence or microbial infections, and then they become kind of inflammatory mitochondria, but we really didn't understand the mechanisms. And these days we've got a very clear understanding of the mechanisms, and it's through, at least in part, mitochondrial hyperpolarization. I'll show you another diagram on that in just a moment. So some other things that have changed, Mike also mentioned Treg deficiency, Th1, Th2, Th17 cells. Those are very important, and those are affected through mitochondrial dysfunction, but also mTOR activation, which I'll show you in just a moment too. That's kind of my new area that I'm highly interested in, is mTOR and mitochondrial hyperpolarization, and also microglial activation. I'll show you that in just a second. And then something else that I've gotten into lately, and Mike and I have talked about this, because a new article was just published, I believe, in December of 2014, so it's pretty fresh, is how even gastrointestinal bacteria change global whole body DNA methylation patterns. So what we're seeing now is how gut microbiome, through different metabolites, for example, can actually affect DNA methylation patterns throughout the entire body. So when you add all of this up, I think this provides us new opportunity to understand what is this thing that we've been calling now, you know, for 107 years, dysbiosis, you know, since Meshchekhov published Prolongation of Life. So I think we're, you know, refining our understanding of things. Another component of this is what's called central nervous system sensitization. You see conversations about this quite often, more and more all the time actually, when you talk about chronic pain, fibromyalgia, depression, fatigue, and I'll touch on that in a diagram that I just made last week. So again, all that can flow down into mitochondrial dysfunction, and all these things kind of coalesce into what we see clinically, which is autoimmunity, inflammation, metabolic dysfunction, insulin resistance, etc. Those are all just different patterns of basically different variations on the same theme, basically. I've published quite a bit on this. A lot of my articles are available for free online, so if you just Google my name and dysbiosis, or use whatever search engine you want, you'll find a lot of things I've got out there for free. And this was kind of this was as far as I had gone as of last year. I'm working on a new monograph that'll come out pretty soon. And I'll show you a diagram from that. So, for example, here's one of the topics that I'm acutely interested in right now, and this is what I call microbe-mediated microglial activation. So within your immune system you have, within your central nervous system you have an immune system, right? Those are called microglia or microglia. And when those become inflamed, either by their sensing of microbial products or through systemic elaboration of inflammatory cytokines, those actually create some of the neurologic symptoms or syndromes that we see in clinical practice. So again, I'm just trying to connect a few dots here, and then we'll get into the cases. But this is something that I want everybody to be aware of, and it's something I'm acutely interested in right now, which is why I couldn't resist putting this slide in. So, and this is in the video that I just posted online like 2 days ago. So it's brand new and fresh, and the whole thing is there. But what I want to do in this conversation is connect microbes, dysbiosis, with microglial activation and ultimately pain, inflammation, as experienced neurologically, and perhaps some other neurologic syndromes too. So here, for example, you see a new article talking about NAC, N-acetylcysteine, in psychiatry. Another article using that same intervention in kids with autism. Again, another article addressing brain inflammation in autism. And then this rather classic article that was published back in 1994 called The Brain on Fire. So I just want to show you how we can connect all of that together rather quickly. So I mentioned microglial activation. Again, these are basically the immune cells of the central nervous system. And in this context, we're going to talk about mostly in the brain. Microglia or microglia actually are able to sense and respond to microbial debris, other inflammatory stimuli, such as resulting from mitochondrial dysfunction, and also inflammatory cytokines that are elaborated in other parts of the body. So for example, even if there's no active infection within the brain, and usually we don't see that except in Alzheimer's and maybe multiple sclerosis, these microglia can respond to the sensation, their reception, I should say, of inflammatory cytokines that are peripherally secreted. When that happens, the sequence of events is that we go from microglial activation to astrocyte activation and then ultimately astrocyte degeneration. And it just becomes a vicious cycle where we see excess glutaminergic neurotransmission, mitochondrial dysfunction, and then here's the brain trying to cope with all of that. These microglia and astrocytes, other glial cells, are actually controlling neurotransmission, and that's how we end up with this concept of brain on fire. So I'm just trying to extend the conversation a bit and kind of show you what's on the horizon of some more conversations that are kind of pending. What we're going to focus on right now is understanding what I call the TML, or total microbial load, in the perpetuation of chronic inflammatory diseases. And as most of you know, if you've heard me lecture over the last couple of years, I don't use the word chronic anymore. I use the word sustained. So rather than looking at these as chronic inflammatory diseases, like most of us learned in medical school, I prefer to use the term sustained inflammatory response, actually. Because if I say, or if I accept the model that lupus is a chronic inflammatory disease, what am I going to do about it? I've already started from the presupposition that this is chronic, right? If I change the language just a little bit and say this is a sustained inflammatory disease, I'm still talking about something that exists on a long-term basis, but it changes the way that I approach it, right? If I say to you this is a chronic problem, you're kind of stuck just pharmacologically managing it. If I say this is a sustained problem, it changes the way you perceive it, because then the questions that arise are, well, what's sustaining it, right? And then you're able to, I think, be more assertive and ultimately more successful as a clinician. We'll talk about laboratory methods here and there. I know that David talked about that earlier, so I won't spend a lot of time on that in my limited time. We'll talk about dysbiosis beyond the microbe. So when I talk about dysbiosis, as you'll see on one of my upcoming slides, it's a relationship between the host and the microbes. It's not simply the microbes. You know, for example, if you look at a classic example like reactive arthritis, out of 100 people, I'm just making up numbers here, but out of a big group of people, they all might have certain triggering microbes. But in one person, you might see that they develop reactive arthritis, iritis, sacroiliitis, etc. So the issue cannot be that of simply the microbe, pretty much in any form of dysbiotic clinical presentation. We have to look at what's going on with the host. So my definition of dysbiosis is we have to look at it as a relationship. My protocols for anti-dysbiosis. So if we're going to try to alleviate this problem, what are the approaches that we can use? If we just think about microbes, then we're going to be inclined to use like antimicrobials, right? Because if you get rid of the microbe, then no dysbiosis can therefore exist. But you have some other options too. So one option that you have is antimicrobial therapy. Another option that you have is any type of immune restoration, what I call nutritional immune restoration. The fact that these patients have dysbiotic microbes or dysbiotic inflammation, by definition, therefore, means that they've had some type of microbial or polymicrobial colonization, which, therefore, by definition, means they are a susceptible host to that colonization. So if we make them less susceptible by enhancing natural immunity, I think that gives us another advantage. I think that's also why you see some of the antibiotic clinical trials not have much long-term success. They might succeed for a little while, then the patients relapse. That's because no intervention was done to actually restore immune function to combat the recurrence of the colonization. And then number 3 here is we can enhance tolerance, and I know Mike touched on that earlier. I can certainly talk about it as well if we have time later. And I've got a protocol for that, which I call nutritional immunomodulation, which continues to grow all the time. So again, my definition here, a relationship of non-acute, non-infectious host-microorganism interaction that adversely affects a human host. That's very vague. It could be inflammation, it could be metabolic syndrome, insulin resistance, it could be psychiatric illness, etc. And for example, I think autism is a good example here, where microbes play a part via glial activation. Usually no signs of classic infection. Location of active dysbiosis often has no consequence clinically. For example, if patients might have arthritis or cognitive dysfunction, something like that, and they may have no gastrointestinal symptoms at all, or at least non-specific ones, maybe a little bit of tendency towards constipation or diarrhea, but their symptoms could be somewhere else. That's perhaps obvious by this date and time. So here's the way that I used to look at it, and I still look at it this way even though I've expanded this concept quite a bit. When we talk about dysbiosis, we have to appreciate that dysbiosis can occur in several different locations. Gastrointestinal tract, of course, is the prototype because that's where 95% of our bacteria are. But people can have problematic bacteria in other locations as well. But again, gastrointestinal is the prototype. But people can have orodental dysbiosis, cynorespiratory dysbiosis. Parenchymal or tissue dysbiosis, I think, is gaining a lot of ground lately, especially with chronic low back pain and diabetes, and also psoriasis. Genitourinary is a big problem for patients with rheumatoid arthritis and ankylosing spondylitis. Cutaneous or dermal dysbiosis would be particularly notable in kids who have atopic dermatitis or eczema. And environmental dysbiosis means that people are responding to their reception of microbial particles that are just in the air, for example, sick building syndrome. These are some of the microbes I've seen in my own practice. I just made a quick list here. And this was my list of mechanisms. I've expanded this list quite a bit lately, mostly on a weekly basis for the last couple of weeks. And this is what I'm working on now. I'll show you this model in just a minute. So we've talked about what dysbiosis is. We talked about the subtypes by location. Multifocal dysbiosis is a term that I made up about 10 years ago. And then multifocal polydysbiosis, which I think is actually even more accurate. But if we combine the total bacterial load with the total viral load, then we get what I could reasonably call the total microbial load. So viruses are another big topic these days, for good reasons and bad reasons. But in terms of autoimmunity and inflammation, we're seeing a lot of research come out on viruses. And obviously a relationship exists between bacteria and viruses and other viruses. So I can touch on that later if we have time. So here's the diagram that I just showed you. Again, it's just another way of looking at things. And I think the more models that we have, the more diagrams that we can create, ultimately the more accurate our perception of this is. So if you think of dysbiotic foci or locations, you've got all these locations, not only including bacteria, but also viruses. So you add all that together and you get all these microbial molecules and messengers, some of which are listed here, and then the mechanisms I've listed here, and then you see some classic clinical prototypes down here. Hepatic encephalopathy, central sensitization, immune complex deposition, and reactive arthritis. Those are just kind of prototypes which serve as models for other clinical entities like rheumatoid arthritis or lupus or fibromyalgia. So I'll go through a few details here, some of which I'll skip over. So I already talked about mitochondrial hyperpolarization. These are the new ones. Mitochondrial hyperpolarization and mTOR activation. Central sensitization, I mentioned that. Epigenetics, so that's changes in epigenetic expression and profiles based on the total microbial load, especially in the gastrointestinal tract. Another quick conversation here about total viral load. So in your body, in everyone's body, in your patient's body, you've got what I call total viral load, which is exogenous viruses, endogenous viruses, and also bacteriophages, which are in the gut and mostly associated with, as you would expect, inflammatory bowel disease, especially Crohn's disease. But I think this is an area of conversation that we need to include within our conversation about dysbiosis. So moving on from there. So I know Mike mentioned mTOR, and by the way, I don't think we've ever talked about mTOR too much, meaning it's a new concept. So I know Mike talked about it. That's why I wanted to talk about it here as well. At least that's part of the reason. I think this is a really fascinating topic. Like I said, I've got a new video online for free that you can take a look at. But what we're going to look at here in relation to this conversation is how bacterial endotoxin actually promotes mitochondrial hyperpolarization, and that leads to mTOR activation. So then as we go on to the next slide and you see the effects of mTOR activation, you'll see how you can connect bacteria with chronic inflammation and autoimmunity, for example. So We go from bacteria to mitochondrial dysfunction and mTOR activation. And then on the next slide, we see how mTOR activation can cause chronic inflammatory disease. And it's actually through at least two or three different mechanisms. One is the activation of these Th17 cells. Another is the reciprocal inhibition of these T regulatory cells. And then we get some non-specific pro-inflammatory effects like NF-kappa B activation. So you can see that this just becomes a big mess, which is why we have to intervene and normalize the human microbiome, which is another popular term these days. So that's what we're going to talk about doing. Again, here's your mitochondria, and your mitochondria is, of course, affected by your total microbial load. In certain microbes, for example, herpes simplex virus, which is seen in about 50% of the adult population worldwide, actually kills mitochondrial DNA. So that's why you see some association with mitochondrial disease and herpes simplex type 1, specifically Alzheimer's disease. This is the article I published early last year, late 2013, January 2014. Mike mentioned that earlier. It's online for free. And then here are some classic clinical presentations that we see associated with dysbiosis. And as you would expect, these are different patterns of inflammation resulting from imbalances of immunophenotype, the Treg, Th17 imbalance, and specific genetic patterns that the host has, as well as the microbial, metabolic, and molecular profile. For example, Wegener's granulomatosis is a vasculitic autoimmune condition, which the dominant model for that right now is that it's triggered by what's called haptenization between an enzyme from Staphylococcus aureus with these endothelial cells. That's one of the dominant models, probably not the only model, but it's certainly one that can't be ignored. So that's one way that microbes can trigger inflammation, is by producing certain enzymes or antigens, and then the immune system responds to those enzymes or antigens, and then we see this inflammatory state evolve from that. That's a rather simplistic example. These others are, I think, more complex, especially rheumatoid arthritis. But the interesting thing about complexity in this regard is that the more complex things are, I think that actually gives us more opportunity to understand them better. It doesn't, like, I don't see complexity as something bad. I see complexity as an opportunity, because something I started to write the other day, like, I don't know if I'll say it right now, because I'm still working on this one-liner, but my one-liner is something like, complexity is simply the illusion of misunderstood simplicity. So if something's complicated, great. Like, I see that as an opportunity to understand it better. And that's why, like, I think of these conditions, well, Sjogren's is pretty complicated. But I think rheumatoid arthritis maybe is the most complicated, meaning that we understand the most about it. But that's great, because we can, it's kind of a, on occasion, a frequent occasion, it can be kind of a slam dunk. So, like, if I get a patient with rheumatoid arthritis, I'm happy. Those are the patients I want. What I used to teach, and I don't think we actually have to teach this anymore, is how to use lab tests along with your other physical exam, and lab tests meaning like your standard lab tests versus like these more functional tests like intestinal permeability and dysbiosis. I think it's all a continuum. We all have to practice good medicine, but I don't think that that's discontinuous with doing what we might call functional medicine here. So, basic labs, these are you've got this list. These are just the basic labs we all do. And then you just look for abnormalities and fix them. I mean, it's not that complicated. This is it? Maybe it is complicated? I don't know. This is a diagram I made for the Institute for Functional Medicine many years ago, kind of using some of their work and combining it with my own ideas. This is also available on my website and probably some other people's website as well. It's an article that I published back in 2006, I believe, in, what was it, Integrative Medicine. So the purpose of this diagram is just to help you all understand probably something that you already understand, and that is what goes on in the gut can affect the whole systems biology of the patient that you're working with. You may have seen this diagram from my work previously. What we're going to stop and focus on right now is how microbes affect mitochondrial function. And once mitochondrial dysfunction gets initiated, it kind of takes on a life of its own and perpetuates itself. So the effects of mitochondrial dysfunction can start anywhere, and usually it's a combination, but let's just start with microbes and dysbiosis, or let's start with herbicides and chemicals like glyphosate, which most of you all are eating. Especially in America, they eat a lot of glyphosate. It causes mitochondrial dysfunction, and that would be expected to trigger inflammation and other complications of mitochondrial dysfunction like insulin resistance. Some of us think that's what's going on, and probably with good reason. Old diagram, I've certainly modified that over the last short amount of time. This diagram just expresses how mitochondrial dysfunction leads to inflammation. Inflammation also leads to mitochondrial dysfunction. I've also expanded the conversation to include endoplasmic reticulum stress there, and then oxidative stress. So you do see a vicious cycle here, which is what I alluded to earlier. This might be one of the last new slides. This is your endoplasmic reticulum, basically. And one of the insults that your endoplasmic reticulum can respond to is this large category of microbial insults. So when you hear people, if you haven't heard them talk about endoplasmic reticulum stress, one of the things that should get triggered in your mind is that there could be a microbial component to this. Microbes trigger toll-like receptor 4. Toll-like receptor 4 activation causes an inflammatory response of its own, but it also triggers endoplasmic reticulum stress, which is its own inflammatory pathway, and feeds forward and receives feedback from the mitochondria to perpetuate that vicious cycle. So it's a mess. And that's why we see these patients with these long-term sustained inflammatory responses. And I think that we've got a lot of insights, but I don't see those being translated very quickly into general medical practice. I'm not going to spend a lot of time on this, but it is consistent with my own experience and maybe the experience of most medical doctors. I mean, the purpose of medical school really is to make us good diagnosticians and good prescribers, right? But if that's all we learn, then that's all we'll ever do, is diagnose and prescribe. And according to this article published in British Medical Journal, that was the clinical phenotype of the doctors that had graduated. These are, I'm sure, drugs that most of you see on a regular basis in your autoimmune patients. It's a very popular anti-rheumatic protocol. It's also not very effective. If you look at this review article published back in 2012, only 10% of patients get about a 2-year remission with that standard protocol. So I think that's kind of horrid, actually, because, I mean, with all due respect for emergency management, but if I only, helped 10% of patients who come to me over 2 years, I don't think I'd be in business. I had a lot of success when I was in general practice and then later kind of a more specialty practice with autoimmunity, and now we're going to start going through those cases. So that was my intro and perspective and a few tangents here and there just to provide some more contextualization. What we're going to look at right now is this 34-year-old Hispanic man. Mostly this first case, we're going to look at laboratory tests.